Okay, thank you. So I think we'll find some similarities between the last talk and this one in terms of where we are with definitive statements with regard to pulmonary hypertension and heart failure with preserved ejection fraction. I'll start with just a couple minutes on the overall burden of heart failure and why this is an important area in pulmonary hypertension to consider regardless of one's specialty. We're seeing enormous growth in the prevalence of heart failure with anticipated further growth in the coming years. It's the number one cause of why patients are admitted to the hospital now over the age of 65. Many of the patients have advanced forms of heart failure, on the order of about 200,000 patients. The only curative treatment is heart transplant, which is reserved for about 2,000 patients a year. And fortunately, we've made a lot of strides in treatment of patients with heart failure with reduced ejection fraction. I'm not going to go through the slides in detail here in terms of all the studies that have been done, but suffice it to say we've come a long way in terms of our 2-year mortality with addition of ACE inhibition, beta blockade, aldosterone blockade, the newest player on the block, the LCZ686 compound, where we've gotten 2-year mortality rates in active treatment arms down below 20%. We also have several device therapies with defibrillators and CRT devices, pharmacotherapy in more advanced heart failure, and finally destination therapy, LVADs, for patients with LV systolic dysfunction. Here are the results of the 2-year trials in heart failure preserved EF with mortality benefit. It's kind of bleak, as you'll all see. So I think with this in mind, there really is an urgent need to apply subphenotyping or subcharacterization of these patients in order to improve our targeted approaches to interventions. And I think one of those areas is the right ventricular pulmonary vascular axis or unit, if you will, as a candidate subphenotype that's present in a subset of patients with heart failure preserved EF. And because of the lack of proven treatments for this disease, I think it's really important that we delve into this condition and look carefully at how these patients are being characterized, and if there is a subset of them in whom we could use some of the really great work that's been done in pulmonary arterial hypertension and apply it to patients with heart failure preserved ejection fraction. So I want to start with how heart failure preserved EF is defined, because I think it's an important consideration, particularly as we begin to look at and interpret clinical studies in which the prevalence of pulmonary hypertension has been described, for example. We have to look at how patients are being defined. And so, the definition of heart failure, there's several out there. The Braunwald definition is a clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the heart to fill with or eject blood. A pretty broad definition. One of the challenges with heart failure preserved ejection fraction is we tend to define it on the basis of what it's not. It's not left ventricular systolic dysfunction. Again, that leaves a pretty broad category there. And if we look at some of the major epidemiologic studies that have tried to capture the prevalence of pulmonary hypertension and heart failure preserved EF, they've actually used the Framingham heart study criteria to define heart failure. And so I've listed them up here because they don't typically make it into the print of some of the journals that these epidemiologic studies have been done on. But here are the major and the minor criteria. Someone can fulfill 2 major or 1 major and 2 minor criteria for the diagnosis of heart failure preserved ejection fraction. But just to kind of muddy the waters further, if we look at this definition and we look at all the things that I've outlined here, all of these really reflect what's happening on the right side of the heart, right? Neck vein distension, hepatojugular reflux, high CVP, ankle edema, hepatomegaly. So we have to be careful in terms of what we're calling heart failure with preserved ejection fraction. I go so far as to say patients that have pulmonary arterial hypertension have heart failure with preserved ejection fraction. It's just that it's right heart failure. So I think that, as was nicely described earlier in the talk by Neil, we have to first start by carefully delineating what is the burden of left heart disease in terms of defining patient populations before we can go further in terms of what the burden of pulmonary hypertension is. And so this is a busy table here from a recent Group 2 PH position paper that we put out from the ISHLT working group. But basically some of the historical features, if there's a known insult to the left heart in terms of structural heart disease, certainly comorbidities that tend to cluster with left heart disease and diastolic dysfunction of the heart, kind of predominance of left-sided symptoms with orthopnea and PND, left-sided S3 or S4, left-sided murmurs. In terms of some of the history and physical exam, I won't read through all of these characteristic findings in patients that have non-group 2 pulmonary hypertension, but it's important to first differentiate what the burden of left heart dysfunction is in terms of thinking about PH in patients with heart failure preserved EF. If we move on to the electrocardiogram, certainly there can be clues in terms of a right heart strain pattern. There can also be clues if there's evidence of previous myocardial injury on the electrocardiogram. The echocardiogram, as has previously been discussed this morning, it can be very helpful in terms of looking at things like left ventricular hypertrophy, valvular heart disease. And then in the right side of the heart, which we'll delve into in a little bit more detail, if the pulmonary hypertension is primarily being driven by a non-group 2 or non-left heart process, I find relative size of the atria to be very helpful. The left atrial size in heart failure with preserved ejection fraction has been considered kind of like the hemoglobin A1C of diastolic dysfunction. You tend to see it elevate over time with high left atrial pressures. So the relative size of the right atrium and right ventricle compared to the left atrium in particular can be helpful. The pattern of the interventricular septum in terms of a flattening or reverse curvature pattern with a predominance of right-sided dysfunction. And then certainly as we move into our invasive hemodynamics, as we've discussed this morning, what is the pre-capillary or post-capillary predominance? Oftentimes we will see both in terms of a mixed picture with high transpulmonary gradient and high pulmonary capillary wedge pressure. We previously discussed the role of exercise in terms of defining elevations in left-sided filling pressures. So with some of the characterization in mind, we can begin to look at the burden and significance of pulmonary hypertension in patients with heart failure preserved ejection fraction. Fair amount of the work I'll share was done out at the Mayo Clinic. This was a group of 203 patients that Carolyn Lamb published on in 2009. They were defined on the basis of Framingham Heart Study criteria, though actually went back in response to review and did make sure that they excluded patients with other forms of pulmonary hypertension. And you can see that 83% of the patients with heart failure preserved EF met this criteria. One can debate whether PA systolic pressure of 35 should be used as a threshold or 40, but you can see clearly a majority of the patients here with heart failure preserved ejection fraction by clinical criteria met this cut point for elevated pulmonary arterial systolic pressure. And importantly, if we look at the pulmonary arterial pressure, you can think about it as somewhat of an integrative barometer in heart failure preserved EF. It integrates the left atrial pressure elevation by definition, and also any contribution of precapillary pressure elevation in terms of the transpulmonary gradient. And so in terms of looking at the classification of patients, the echo-derived PA systolic pressure was the leading discriminator in the diagnosis of heart failure preserved EF. It outperformed other echo parameters like E to E prime ratio, left atrial volume index, and relative wall thickness in terms of ruling in the diagnosis of heart failure with preserved EF. So it's almost a starting point in terms of this elevation in the PA systolic pressure, and certainly a source of many referrals to people who take care of patients with pulmonary hypertension. And importantly, which goes hand in hand with the high prevalence of pulmonary hypertension and heart failure preserved EF, there's also a clear prognostic implication here in terms of the patients with higher PA systolic pressures had worse outcomes in this study. In a larger patient population, community-based cohort of over 1,000 patients from Olmsted County, you can see similarly, after adjustment for age, gender, COPD, other comorbidities, and anemia, there was a significant increase in risk associated with elevation in PA systolic pressure. So we know that there's a relationship between PA systolic pressure elevation and outcomes in heart failure preserved ejection fraction. We know it's prevalent. What about the characteristics that predict elevation in pulmonary arterial pressures in patients that have heart failure preserved ejection fraction? I think this information is really just starting to emerge. I've included some information from a paper that's going to be published next month in Circulation that carefully profiles a little bit over 500 patients from Olmsted County and looks at some of their other characteristics relative to PA systolic pressure and also relative to right ventricular function, which has been a real focal point of the discussions this morning. And you can see that if we divide patients into tertiles relative to their PA systolic pressure, some of the things that not surprisingly emerge, older age was associated with increasing PA systolic pressures and worsening renal function, although several of the other parameters really did not reach differential distribution across the three groups in terms of clinical parameters that can help us to predict who's going to have greater degrees of elevation in their PA systolic pressures. But I think the PA systolic pressure alone is not sufficient to characterize these patients, as is the case with other forms of pulmonary hypertension. We really need to look at the right ventricle, and that was done as part of this study from Mayo Clinic. They did not have the comprehensive degree of detail about the right ventricle that we oftentimes desire for characterization by echocardiography, but they went back retrospectively and looked at what was present, and that included a qualitative assessment of the right ventricle, looking at contractility of the right ventricle as well as RV size, and they looked at RV size relative to LV size in what was deemed a semi-quantitative assessment of RV performance that is oftentimes reported out on an echo as saying the right ventricle was dilated and hypokinetic, for example. So there was a qualitative assessment, and then there was also a look at the longitudinal motion of the tricuspid valve annulus, the TAPSE, in these patients. And so they asked the question as to what extent does right ventricular function play a role in heart failure preserved ejection fraction in terms of predicting outcomes. And importantly, they sought to disentangle pressure in terms of pulmonary arterial pressure and right ventricular function as assessed by echo. So we'll look at that in some detail. So this is the distribution of the TAPSE scores among the patient population with heart failure preserved ejection fraction. And typically 16 is established as the lower limit of normal. So you can see that roughly a third of patients with heart failure preserved ejection fraction were found to have reduced TAPSE scores. If you look at the distribution curves here, you can see clearly there's this leftward skew here in terms of a subset of patients with heart failure preserved ejection fraction that do appear to have impaired right ventricular function as profiled by the TAPSE. So again, we're trying to see if we can hone in on a subset of patients with heart failure, preserved ejection fraction, that may start to look more like our pulmonary arterial hypertension patients in terms of the consequences for the right ventricle. So about a third had low TAPSE scores, and then the next question is, are there certain features of the patients with low TAPSEs that have heart failure preserved EF that can be informative in terms of other company that it keeps? Somewhat to my surprise, there was not differential GFR across the different TAPSE groups, but there were two signals that emerged that I think make physiologic sense. I should have outlined coronary artery disease as well. So coronary disease was more prevalent in patients that had right ventricular dysfunction by TAPSE. Atrial fibrillation was significantly more prevalent in patients that had right ventricular dysfunction, and the presence of permanent pacemaker was much more prevalent. So some of these things don't come as a surprise in terms of thinking about how the right ventricle remodels when it begins to become dilated and hypokinetic. Oftentimes it can ill afford the additional compromise and contractility that comes with atrial fibrillation and the dyssynchrony that comes with right ventricular pacing. It was not reported in terms of the proportion of time at which these patients with pacemakers in place were being RV paced. But obviously this is a preserved ejection fraction group, so this was not patients that had biventricular pacemakers in place. If we look at this data slightly differently and we look at the qualitative assessment of the right ventricle in patients with heart failure preserved ejection fraction, again, these patients were classified as either having normal RV function, which was the majority of patients with heart failure preserved EF, which I think is an important point. This is not, by any means a majority, but those that had either mild or moderate to severe right ventricular dysfunction based on indices of contractility and RV size, you can see again, we really don't see much of a difference in terms of their age, gender, body mass index, whether or not there's diabetes present, but atrial fibrillation and pacemaker clearly emerged. There is obviously interrelationship between TAPSE and this semi-quantitative assessment of the RV, although the correlations between the categories were not as good as one might have expected. So again, atrial fibrillation and pacing emerged from this analysis as well in terms of the company that right ventricular dysfunction keeps in patients with RV systolic dysfunction and HFpEF. The investigators went on to look at TAPSE scores as predictors of survival, and you can see in the univariate analysis here, the lowest tertile had the worst outcomes. If we look at semi-quantitative RV dysfunction, it seemed that any degree of RV dysfunction, whether it was mild or moderate to severe, had this significantly worse prognosis. Again, somewhat mirroring the data that we've seen in left ventricular systolic dysfunction in terms of the right ventricle. I also had tricuspid valve regurgitation here. Those that had moderate to severe TR also had significantly worse prognosis. And then they went on, sorry to be showing all these tables, but this data is kind of all hot off the press. And I want to focus on the bottom part of the panel here. It may be a little bit difficult to see, but this is basically a multivariate analysis where they adjusted for comorbidities, for presence or absence of COPD, for example, and obstructive sleep apnea, age, gender. And what they found was they looked at all-cause mortality, cardiovascular mortality, and first heart failure hospitalization, as well as all-cause hospitalizations. And they found that both of these metrics of right ventricular dysfunction, even after adjusting for pulmonary arterial systolic pressure, were both significant predictors of cardiovascular mortality as well as first heart failure hospitalization. The best performance was from this qualitative assessment of right ventricular dysfunction in patients with heart failure. But there was an independent association with both PA systolic pressure per standard deviation as well as the presence of right ventricular dysfunction in terms of predicting poor outcomes in patients with heart failure preserved ejection fraction. So I think the next question really becomes, are we just seeing the advanced stage of diastolic dysfunction of the heart with highly elevated left atrial pressures, for example, that the right ventricle is unable to handle that degree of afterload? Or is this perhaps a distinct phenotype of patients in heart failure preserved EF who develop this right ventricular pulmonary vascular dysfunction? And I think we can look at the data from the current study that I presented for some clues to that. So to focus on the top part of the screen here, if you look at the difference between those patients who were deemed to have right ventricular dysfunction and those who were not, their LV mass, their E prime, and their estimated LV filling pressures based on E to E prime data were the same in both groups. So it did not appear to be just that the left atrial pressures were higher and that the degree of LV dysfunction was greater in those that develop RV dysfunction with heart failure preserved EF. And importantly, despite these estimated to be equal left-sided filling pressures, the PA systolic pressure was 32% higher in the RV dysfunction group, which leads me to conclude that there is a precapillary predominance of the pulmonary hypertension that is present in these patients who develop RV dysfunction with their heart failure preserved EF. And if we circle back to the paper from 2009 from Carolyn Lamb, they looked at PA systolic pressure as well as pulmonary capillary wedge pressure. Again, this was estimated on the basis of E over E prime data from the Mayo Clinic, so not a perfect measured wedge pressure or left atrial pressure. But I want to point out the fact that while, yes, there is a relationship here between the PA systolic pressure and the pulmonary capillary wedge pressure, I'm particularly struck by the amount of heterogeneity in the data here. You can see that some of the patients had estimated pulmonary capillary wedge pressures of about 25, and their PA systolic pressures were in the 30 to 40 range, and others are way up here. So the strength of association is relatively modest, and I think we need to begin to focus on who are some of these patients with this out of proportion degree of pulmonary hypertension with heart failure preserved ejection fraction, particularly if those are patients whose right ventricles are feeling the consequences of the high PA systolic pressure. And so the RV dysfunction does appear to be present in this cross-sectional retrospective analysis when there's a high precapillary contribution to the PA systolic pressure. So we editorialized this paper and put this diagram together for the paper that's going to be coming out in December. And I think that there's this progressive process in patients that have heart failure preserved ejection fraction. We see an early rise in left atrial pressure that sometimes needs to be discerned with the stress of exercise or with a saline challenge, for example, and we see elevation in left atrial pressure. With progression of the disease, we see more overt heart failure preserved ejection fraction with elevated left atrial pressure, and then it appears with this elevation in the transpulmonary gradient over time. And I will add that there's been a paucity of studies done with invasive hemodynamic monitoring on a large-scale basis with heart failure preserved EF. So this is really from echocardiographic data. But when we see this combination of high transpulmonary gradient and left atrial pressure that causes this transformation from a reactive to a more fixed pulmonary hypertension, we begin to see this maladaptive right ventricular response where instead of handling increased afterload by adaptive hypertrophy, we begin to see right ventricular dilation and decreased contractility. And it appears that some of the clinical parameters here that may be intervening and playing a role, clearly this is a much more common observation in patients that have underlying atrial fibrillation, right ventricular pacing, coronary artery disease, representing potential opportunities in terms of how we manage these conditions in patients who we're seeing undergo this transformation. In terms of what the mediators are here, I think that's really an open question. Is this a long-term reaction to high left atrial pressures in terms of remodeling of the pulmonary circulation? Does it reflect decreased availability of nitric oxide and cyclic GMP signaling? Is it endothelin mediated? Is it hypoxemia mediated? I think that's really an open question here that needs more investigation. So in terms of perturbational studies, we discussed these earlier this morning. I won't dwell on them, but whether it be through exercise or through volume challenge can certainly be helpful. This paper from Barry Borlaug and colleagues looked at exercise responses in patients who basically had normal PA pressures and normal pulmonary capillary wedge pressures at rest, and found that this exaggerated increment in PA pressure was helpful in differentiating patients with heart failure preserved EF from the controls. And really there's a predominance of left atrial contribution to this elevation in PA pressures during exercise. As a group of patients that came through our laboratory with heart failure preserved EF, we see a different profile than what we saw with heart failure reduced EF, in that the PA pressure flow responses are steep compared to controls. But notably, at least in the cohort that we studied, there was a real post-capillary predominance of why that slope was elevated, with a 3 millimeter of mercury contribution to the slope from the wedge pressure, and really the transpulmonary gradient slope did not differ from the controls in this study. So we saw that the patients that we investigated did not have a high burden of precapillary pulmonary hypertension, which may be telling as I run through some of the intervention studies that have been performed in the final part of the lecture. So in terms of some of these perturbational studies with exercise, it is helpful to look at relative contributions to the PA pressure during exercise. What happens to the transpulmonary gradient relative to the wedge pressure? What happens to right ventricular function during exercise? Those can be used to potentially consider agents that vasodilate the pulmonary circulation, though more evidence is clearly needed. The more common scenario by far is that the wedge pressure rises abruptly during exercise in patients with heart failure preserved ejection fraction. And in those patients, we really need to focus on optimal diuretic strategies and some of the treatments that are under investigation for diastolic dysfunction and heart failure preserved EF. So what about a therapeutic approach? Again, another busy slide here, but I just want to emphasize, this is from the same ISHLT summary statement from a couple of years ago, looking at pulmonary vasodilator treatments with prostacyclin and endothelin antagonists. This is all comers with heart failure, not specific to heart failure with preserved EF. But I think it does highlight the patient populations that were studied with these pulmonary vasodilators in the studies that have been done to date. And I highlight a few in terms of the inclusion criteria for these studies. None of them based their intervention on evidence of a significant precapillary burden of pulmonary hypertension or significant right ventricular dysfunction. Some of the trials with endothelin antagonists, for example, one of the inclusion criteria was evidence of pulmonary edema, acute hospitalization for heart failure. So, one could imagine that if we take a patient population with pulmonary edema and give them a pulmonary vasodilator, based on what we now know, we are unlikely to be doing them a great service. But I think it's important to point out the fact that the studies that have been done to date, the first study with epoprostenol and subsequent studies with endothelin antagonists in patients with heart failure, this was a predominance of heart failure with reduced EF, were uniformly neutral or negative. So really, we have no evidence basis for either of these drugs in patients with heart failure that have been studied to date. There was a study that many of you may be familiar with of Cetaxetan and heart failure preserved EF, 192 patients. It was published earlier this year that looked at exercise duration with a primary endpoint. This did reach statistical significance with about a 60-second placebo-corrected difference in exercise duration with this endothelin antagonist. The data in terms of the secondary endpoints, there was also hypothesized to potentially be improvements in diastolic function, LV mass. These did not improve. This was not a study that was specifically targeting patients with out of proportion pulmonary hypertension, but represents some of the data that's currently available. There's also a trial that's currently enrolling patients that has specifically out of proportion pulmonary hypertension with left heart disease with the macitentan that is going to enroll 60 patients looking predominantly at safety that's currently enrolling. So what about shifting to the cyclic GMP augmentation strategies that have been nicely covered this morning in other lectures? There are several potential ways of targeting this axis. I'm going to focus on some work that's been done with PDE5 inhibition to date in heart failure with preserved ejection fraction. We do have the left trial, which was done in LV systolic dysfunction with riociguat that was a neutral trial because it did not meet the primary endpoint of reducing pulmonary arterial pressures, though pulmonary vascular resistance did fall. But there's, suffice it to say, several different strategies by which we can augment cyclic GMP that may or may not be of utility in patients with heart failure preserved EF. Many of you are probably familiar with the RELAX study that was published in JAMA, in which, as a heart failure network, we studied the sildenafil versus placebo in patients with heart failure preserved ejection fraction and asked whether or not there would be an improvement in peak VO2. And I think that the people in the pulmonary hypertension community have appropriately questioned as why it was that the patients that were enrolled. We basically took all comers with heart failure preserved ejection fraction, which I'll show you in a few moments. And there was quite a bit of debate in designing the study as to whether or not we should design this study to specifically focus on patients that had right ventricular pulmonary vascular dysfunction with their HFpEF or take all comers with heart failure preserved ejection fraction. The latter kind of won out in this case, largely because preclinical data pointed to mechanisms beyond the pulmonary circulation by which PDE5 inhibition may be beneficial. For example, previous studies have shown reduction in systemic vascular resistance, improvement in endothelial function and ergo reflex activation, improvement in both LV and RV remodeling with regression of LV hypertrophy with PDE5 inhibition, potentiation of natriuretic peptide responsiveness at the level of the kidney. And so we went ahead and basically rolled in all comers with heart failure preserved ejection fraction into this RELAX study. It was randomized 1-to-1. Before I show you the results, I'll show you kind of what side I was on based on this study that we presented earlier today in LV systolic dysfunction, in which the patients that had the lowest RVEF and the highest pulmonary vascular resistance were the ones that benefited the most from being on PDE5 inhibition. But this is the RELAX trial. EF above 50%, NYHA 2 through 4, tried to enrich the population based on having had a heart failure hospitalization within the last year or a cutoff for NT-BNP or BNP level being sufficiently elevated, and they had to have reduced peak VO2. Patients had cardiopulmonary exercise tests, subset had MRI or echo, 6-minute walk, and biomarkers done at baseline, up titration of Revatio to 60 milligrams every 8 hours, and they came back in for their testing at 24 weeks for the endpoint of the study, which was change in peak VO2. This is the study population. You can see their age, notably mean BMI was 33 in both arms. There's a mixture of NYHA 2 and 3 heart failure and a lot of hypertension, fair amount of coronary artery disease and diabetes, and atrial fibrillation in the baseline study population. Again, there was no criteria around minimum pulmonary arterial pressure or evidence of right ventricular pulmonary vascular dysfunction. And this was the results of the study. I read the exercise tests in my lab, and they were resoundingly neutral. You can see there was no difference between the two groups in terms of the change in peak VO2 at the conclusion of the trial. And not only did VO2 not change, 6-minute walk test did not change, NT-BNP levels didn't change, cyclic GMP levels didn't change, which really led us to kind of call into question as to how well we're actually achieving augmentation in cyclic GMP signaling with blocking hydrolysis of cyclic GMP with PDE5 inhibition in this patient population. And LV mass didn't change either in terms of some of the secondary endpoints. I'll conclude with contrasting this with a different study that kind of comes back to this issue around carefully phenotyping patients. This was a single center study done with the same drug, Sildenafil, by Marco Guazzi and colleagues in Italy. And they enrolled 44 patients in a double-blind placebo-controlled trial, Sildenafil versus placebo, heart failure, preserved ejection fraction. But these patients had a very different characteristics than the patients that were enrolled in RELAX. You can see that the average right atrial pressure was 23 in this group, and the average pulmonary capillary wedge pressure was 21.9. So the right atrial pressure was in excess of the pulmonary capillary wedge pressure, which is not the kind of run-of-the-mill heart failure preserved ejection fraction patient that many of us see. Pulmonary vascular resistance was in excess of 3 Wood units. TAPSE scores were 11. So this is a patient population that very much fits into the group that I was describing earlier in terms of having evidence echocardiographically and by invasive hemodynamics of this right ventricular pulmonary vascular dysfunction. And in that context, this was an overwhelmingly positive study. You can see the data that's presented in tabular form here. Right atrial pressure was cut in half. The wedge pressure decreased modestly. Transpulmonary gradient came down to next to the 0. Pulmonary vascular resistance improved markedly at the midpoint of the study and was sustained throughout, and TAPSE scores improved. So this is a highly selected population, and I think that to potentially consider pulmonary vasodilator therapy in patients with heart failure preserved EF, there really needs to be this a careful subcharacterization of these patients in terms of how they look. So in terms of therapeutic interventions, we don't have any evidence to suggest that epoprostenol is of any benefit. Endothelin antagonists in heart failure reduced EF have shown neutral or negative results. We have the one trial that's ongoing with macitentan and one study that suggested improvement in exercise capacity with endothelin antagonism. And then for PDE5 inhibition, really the jury is still out. There is some promise in terms of highly selected patient populations, but it's clearly not for use in all comers with heart failure preserved EF. So I'll stop there and happy to take any questions.